All right, guys. So today's talk is going to be on the ED evaluation of subarachnoid hemorrhage. My name is Mike Hale, and I'm a PGY5 in the FR Emerge program. Before we get started, I'd like to thank the following people whose commentary, feedback, time, and advice was instrumental to putting this talk together. The objectives for today are going to be to provide a nuanced approach to the workup of subarachnoid hemorrhage in the emergency department. We will explore alternative etiologies of thunderclap that we should be considering. And ultimately, I hope to improve the quality of our shared decision-making discussions as it relates to the workup of subarachnoid hemorrhage. So to begin, let's define the problem. As we know, headache is a common emergency department presentation, making up 2% of all ED visits. Dangerous headache is much less common. And when we're talking about subarachnoid hemorrhage, we're talking about 1% of all headache patients. So at TOH, based on our current patient volumes, this translates to about 35 subarachnoid hemorrhages per year. And that's between both campuses. Obviously, we're not talking about transfers here. But let's make it a little bit more personal. Let's take an average emerge doc working about 14 shifts per month. If they see between 20 and 25 patients per shift, this doc is going to diagnose, on average, 1.2 subarachnoid hemorrhages per year. Say this doc loves their job and they work a long and illustrious 40-year career. Over this time, they're going to see 50 subarachnoid hemorrhages, and that's over the course of their working life. And this is the number I want you to remember, 50, because understanding this is going to be really important when we get into discussing our acceptable miss rates later. So why do we care? Well, obviously, it's because this diagnosis results in bad outcomes. Case fatality rates approach 50%, which may actually be an underestimate due to the large percentage of patients that die before reaching hospital. Of those who survive, another half will experience chronic disability and a significant reduction in health-related quality of life, leaving only a minority of patients to emerge on the other side of this diagnosis unscathed. We also know that those who are missed at the time of initial medical contact have even worse outcomes due to rebleeds that are often worse than the sentinel event, hydrocephalus, and vasospasm. Because the patients that are missed are the ones that present neurologically intact, getting this diagnosis right is really important. So what we do in the emergency department really matters. Like most conditions, subarachnoid hemorrhage has a spectrum of presentations. On the left, we have the severe presentations, focal neurological deficits, altered level of consciousness. The decision to pursue further diagnostic testing is straightforward, and the findings are unlikely to be subtle. These aren't the patients we're going to be at risk of sending home, and our testing is likely to be high yield. In the middle represents our classic case, the thunderclap headache, severe, sudden, textbook. They may have some neck pain, vomiting, a loss of consciousness. In these patients, we have a high index of suspicion, and further testing is clearly warranted. But it's the patients on the right that make emergency medicine so challenging. They present with headache only, no thunderclap, a completely normal neurological exam. Maybe they even have a history of migraines. If a large proportion of patients presented in this way, it would take a tremendous amount of resources to capture them all. So let's take a look at how they present. So first, looking at patients with the diagnosis of subarachnoid hemorrhage, and we see that 83% of them actually present with a thunderclap headache. 95% said it was the worst headache of their life. 74% had neck stiffness. Over 60 had some vomiting. Well, only 13% had a loss of consciousness. I present these 5 clinical features because they were the ones that were consistently more common on a percentage basis in patients with subarachnoid hemorrhage than in those without, in a statistically significant fashion. The problem lies in the fact that subarachnoid hemorrhage is a rare diagnosis, 50 cases over the course of your career. So although the majority of patients with subarachnoid hemorrhage present with a thunderclap, they say it was the worst headache they've ever had, they have neck stiffness, it turns out that these features aren't overly predictive. If we look at all comers presenting to the emergency room with acute headache peaking within 1 hour, Any one of these features is more likely to be present in a patient without subarachnoid hemorrhage than with. And this just relates to how common headache is compared to the relative rarity of subarachnoid hemorrhage. And as it turns out, no single feature can substantially increase a patient's pretest probability of disease. This seems surprising. Part of the problem likely lies in our own understanding of the term thunderclap, but also how we're explaining it to patients. Neurosurgeons actually put a lot of weight into how a patient presents. When they describe a thunderclap headache, they refer to a 10 out of 10 headache that is instantly peaking, snap of the fingers, no headache, and then baseball bat to the head. Dr. Sinclair was saying that he sees a lot of patients that say the headache was instantly peaking, but when he describes it in this way, they realize that it probably wasn't. And so I think describing what we mean in more descriptive terms like this will provide some more predictive value. So when thinking about that classic presentation of subarachnoid hemorrhage, I would encourage you to think about Sammy Sosa, Mark McGuire, Donnie Donowitz, felt fine, and then baseball bat to the head. When patients present in this way, you want to be taking them seriously. So when do I consider the diagnosis? So I'm going to be considering it in patients with headache of at least moderate to severe intensity. This headache needs to be peaking within 1 hour, and there's going to be no clear alternative cause. And applying these criteria, we're going to be casting a pretty wide net. And if we do this, we are left with a pretest probability in the range of, 7%. And this is taken from combining data from Dr. Perry's studies. So when do I worry? It's that classic story, true thunderclap headache, 10 out of 10, instantly peaking. Because if you combine this with one of neck stiffness, vomiting, or loss of consciousness, you're looking at a pretest probability in the range of 25%. And this may be more depending on the number of additional features present. So to summarize, subarachnoid hemorrhage is an uncommon but deadly diagnosis. I consider this in patients with moderate to severe headache that peaks within 1 hour with no clear alternative cause. This does cast a wide net, but when we apply these criteria, we get a pretest probability in the range of 7%. And although no single clinical feature demonstrates significant predictive value, combining multiple factors can be helpful. So that classic presentation of an instantly peaking severe headache with one of neck stiffness, vomiting, or a loss of consciousness should make you worry. This is our high-risk group with pretest probabilities in the range of 25%. So now let's transition and begin talking about the workup of patients with subarachnoid hemorrhage. Let's begin with Dr. Perry and Dr. Steele's landmark paper of the sensitivity of CT within 6 hours of headache onset. Prior to this paper, available research suggested that CT imaging was more sensitive the closer to symptom onset. However, the performance metrics for non-contrast CT had not been thoroughly elucidated, as many of the studies were old and retrospective. So in this study, a group of 5 emergency docs and 1 neurosurgeon looked at the data and saw that sensitivity was pretty good at 12 hours, but maybe not perfect, decided to cut this number in half, and they looked at 6 hours. So I just want to be clear that there's nothing particularly special about this 6-hour time point. It just happened to be the one that was chosen. So with that, let's get into the study.
That was because mine not. That I
think someone's mic's on. So this was a prospective multi-center cohort study at 11 Canadian emergency departments. They enrolled consecutive alert, non-traumatic, neurologically intact patients with headache peaking within 1 hour, or patients with syncope and headache. All patients had a CT scan performed. It was interpreted by a qualified radiologist. And note, this did not need to be a neuroradiologist. Lumbar puncture was performed at the discretion of the treating physician. The primary outcome was performance of CT at identifying subarachnoid hemorrhage within 6 hours of headache onset. Patients with a negative CT and either an equivocal LP or no LP performed were followed at 1 and 6 months by telephone follow-up to ensure that they experienced no adverse events. For those who could not be reached, records were searched at all regional neurosurgical centers, and the coroner's database was also examined. So quite a robust follow-up strategy. And as we all know, they found a 100% sensitivity with tight confidence intervals between 97 and 100%, which I think changed the way a lot of us practice. Before this time, the standard was CT followed by lumbar puncture to definitively rule out subarachnoid hemorrhage. Although it is interesting to note that in this study, less than half of patients actually got an LP in the context of a negative CT head. After this trial, I think it's safe to say that most of us were rushing to get our scans in by 6 hours. And if we did, we were probably stopping there. And this is in keeping with the survey data from the poll I sent out, where 88% of you were doing exactly that, stopping after plain CT. Big thanks to all those who completed the survey. I think it will really make our discussion more enriching. And I just want to make a special shout out to the two absolute animals that decided that they were going to get this done at 3 a.m. Amazing. So the strengths of this study was the first prospective study looking at this question and provides us with some sound evidence to support our decision making. There was a clear definition of subarachnoid hemorrhage and a robust follow-up strategy. Despite this, no information was found on 2% of patients in follow-up. And although it's unlikely that they all died from a subarachnoid hemorrhage, missing even a few patients would really alter the results when we're dealing with perfect sensitivity. The other limitation was that scans needed to be read by staff radiologists. There were 3 misses by emerge docs in the study that were ultimately called back by radiology. This may make the data less useful in community centers. So now let's flash forward to earlier this year and those prospective validation of the 6-hour CT rule that looked at a total of 3,672 patients. This study had the exact same inclusion criteria to the initial study we just talked about. Again, the primary outcome was the performance of CT at identifying subarachnoid hemorrhage within 6 hours of headache onset. And this time around, sensitivity was not perfect, although it was still quite good at 95.5%. Overall, a total of 5 cases were missed. Of those, 2 were actually false positives caused by a traumatic lumbar puncture, and the aneurysms identified on CTA were ultimately deemed to be incidental by neurosurgery. 1 was caused by a miss by radiology, where a blinded reinterpretation of the scan did in fact show a subarachnoid hemorrhage. And 2 of these were true misses. The first was a small non-aneurysmal bleed caused by a rare dural venous fistula. And the second was in a patient with sickle cell anemia and a hemoglobin of 67. So this raises an important caveat that is explored in the radiology literature, that blood is not readily detectable in fluid-filled cavities such as CSF when the hemoglobin concentration falls below 100. So this is an important lesson to keep in mind at the bedside. CT is going to be less reliable in anemic patients. So if we remove the false positive cases, which from a pure method standpoint, we obviously can't do, but from a usefulness at the bedside standpoint is probably quite fair, and leave in the radiology miss, as this is a human error that is going to continue to exist, the sensitivity of CT was 97.3%, which now falls nicely within the 95% confidence intervals of the initial study. So what I think we can take from this is that CT is very good at detecting subarachnoid blood within 6 hours, but it isn't perfect. There are important caveats to consider, such as anemia, and there will always be human error. So if we take the pretest probability of subarachnoid hemorrhage from Dr. Perry's before 6-hour cohort of 12% and apply our CT scan that has a 97.3% sensitivity and a 100% specificity, we get a post-test probability of 0.4%. This leads to a miss rate of plain CT within 6 hours of about 1 in 250. Looking at the group's answers from the poll regarding the acceptable miss rate for subarachnoid hemorrhage, the most common responses were 1 and 2% respectively. 5 of you, or 8%, would accept a miss rate of 0. Now, an important question is, what do we mean when we say acceptable miss rate? Do we mean that we would accept missing 1 to 2% of all patients we work up for subarachnoid hemorrhage? Or do we mean that we accept missing 1 to 2% of patients that truly have subarachnoid hemorrhage? Because these are very different numbers. This number I just gave you reflects 1 in 250 patients you are working up for subarachnoid hemorrhage. If we only look at patients with the disease, plain CT within 6 hours will miss 1 in 37. This now doesn't look quite as good. But remember, subarachnoid hemorrhage is rare. We will see 50 cases over the course of our careers, which means if we apply this rule, we should miss only a single patient. For the remainder of this talk, the numbers I will be giving you reflect patients we are working up for subarachnoid hemorrhage, and I will be applying the Bayesian approach. So now let's transition and discuss the sensitivity of CT beyond 6 hours. And as it turns out, there are only 2 studies that specifically look at this. Dr. Perry's initial CT and BMJ that we discussed at the beginning of this section, and a study published by Backus et al. In Stroke in 2012. Let's start with Dr. Perry's study that looked at 2,179 patients presenting after 6 hours. The first thing I want to draw your attention to is the lower prevalence of disease in the after 6 hour cohort, which is almost half that of the before 6 hour group. Now, I will say that a patient's clinical presentation should trump this statistic, but I think the concept makes sense. Patients with that baseball bat to the head type headache, the Donnie Donowitz, are unlikely to sit at home for 6 hours. The next thing we notice is a much lower sensitivity for CT scan after 6 hours at 85.7%. Not very good when looking at a diagnosis as morbid as subarachnoid hemorrhage. Looking at this data, I think a common mistake that people make at the bedside is they say something along the lines of, even though your CT scan looks normal, at this time frame, CT can miss a certain percentage of bleeds. Your chance of still having a bleed is about 15%, or 1 in 7. And of course, as we know, this is completely inaccurate because what we're missing is the pretest probability. What is the prevalence of disease in this patient cohort before the test is applied? In our case, it was 5.4% in the beyond 6 hour group, or 1 in 20. So taking this pretest probability and now applying our test, what we are left with is a miss rate of less than 1%. And as we will see, this is probably conservative. So now let's take a look at the Backus study, which was published in Stroke in 2012. This was a retrospective analysis of 250 patients from 2 prospective data sets from a tertiary referral center in the Netherlands. Dataset 1 was consecutive patients with confirmed subarachnoid hemorrhage, and dataset 2 was all patients receiving a lumbar puncture with spectrophotometry for xanthochromia. Only patients with a GCS of 15 and no focal neurological deficits were included. Notable exclusions were traumatic subarachnoid hemorrhage and an unknown time of presentation. All scans were interpreted in this study by a neuroradiologist. And their primary outcome was performance of CT at identifying subarachnoid before and after 6 hours. So just to hammer home this point one more time, in the under 6 hour group, they found a sensitivity of 98.5%, which is in line with what we just found with Dr. Perry's validation study. The lone miss here was a cervical AV malformation. But now for what we're actually focusing on, and that's the beyond 6 hour group. And here we see somewhat improved sensitivity at 92.3%. Now, this study had its share of limitations. It was a retrospective analysis. It had a small sample size of 250 patients with wide confidence intervals. Imaging was read by neuroradiologists, and there was selection bias in that one of their cohorts was patients with proven disease. Nonetheless, it adds to a body of literature that is somewhat scant in this area. So in a meta-analysis performed by Carpenter et al. In 2016, the data of these 2 studies was pooled and revealed a combined sensitivity for CT beyond 6 hours of 89% and a relatively strong negative likelihood ratio of 0.11. So looking again at the Fagan nomogram with our pretest probability of 5.4% and our negative likelihood ratio of 0.11, we get a post-test probability of subarachnoid hemorrhage of 0.6% in this beyond 6-hour group following plain CT. So by using plain CT alone, we should miss one subarachnoid hemorrhage out of every 166 patients presenting after 6 hours with acute headache that peaks within an hour. Now again, worrisome clinical features will raise our pretest probability of disease, making plain CT no longer sufficient. But in that patient that presents between 6 and 24 hours without that classic story, this number of 1 in 166 is almost certainly conservative. Because the problem with this data so far is that both of these studies were looking specifically at a 6-hour cutoff. After 6 hours, all patients were lumped into one massive heterogeneous category. In Dr. Perry's study, the missed cases range from 8 hours to 8 days after headache onset. In the Bacchus study, all of the misses came after 24 hours. I don't think I need to convince you that the sensitivity of CT is probably different between 8 hours and 8 days after the onset of symptoms, yet they are both lumped together in this one catch-all group. So what we are still missing is that inflection point. Where does the sensitivity CT really start to decline? And unfortunately, to answer this question, we're definitively, we're going to need future prospective study. Based on the currently available literature, it probably lies somewhere around the 24-hour mark. And up until this point, CT is probably in the low to mid 90s for sensitivity. So to summarize this section, CT performed prior to 6 hours from headache onset approaches but does not equal 100%. Human error exists, and there are notable caveats, such as patients with severe anemia. The inflection point for when the sensitivity of CT declines remains unknown, but based on currently available data, it probably lies somewhere close to 24 hours. So now let's shift gears and consider the high-risk patient where you get back a negative CT, but are still concerned enough that you want to pursue further testing. What is the best way to go about doing this? Historically, the answer to this question was lumbar puncture. And when we talk about lumbar puncture, the pathognomonic finding for subarachnoid hemorrhage is xanthochromia. So now looking at our poll questions for xanthochromia, most people selected between 6 and 12 hours for when it becomes first detectable in CSF. It's almost a perfect bell curve. As for how long it remains detectable, most people chose 1 week. But in both cases, we can see a lot of variability in the responses. So let's dive into it. To detect xanthochromia, there are 2 methods: visual inspection and spectrophotometry. Spectrophotometry uses specific wavelengths of light to detect the absorbance of both bilirubin and oxyhemoglobin. Visual detection, on the other hand, literally consists of a person in a lab holding up a tube of CSF against a white sheet of paper and going, yeah, that looks kind of yellow. Now guess which one we have? Our hospital and about 97% of North American hospitals use visual detection. And although the other way sounds much more technical, the knock on spectrophotometry is its low specificity, as well as the fact that there's no established standard for how to perform this test. So regardless of the pros and cons, what we have is visual inspection. So this is what we'll focus on. We know that the formation of xanthochromia takes time, as RBCs are gradually broken down into oxyhemoglobin and then bilirubin, which both contribute to the discoloration of CSF. As for how much time, the magic number you will often hear quoted is 12 hours, with many proponents recommending that an LP is not done until at least 12 hours after headache onset to ensure that an LP is actually useful. But where does this number come from, this number of 12 hours? As it turns out, this largely stems from a 1989 paper from Vermeulen et al. That was a retrospective study that used spectrophotometry to assess for xanthochromia. They found that between 12 hours and 3 days from headache onset, 100% of patients with confirmed subarachnoid hemorrhage on CT had xanthochromia present. In a subset of these patients, they did serial CSF samples at 1, 2, 3, and 4 weeks to see how long xanthochromia lasted in CSF. And here they found that absorbance peaked at 1 week, was still present in 100% of patients at 2 weeks, 91% at 3 weeks, and 71% at 4 weeks. Now, obviously, there are multiple issues with this study. First, it used spectrophotometry, which, as we just talked about, we don't have. Second, it didn't actually look at patients under 12 hours. So it showed us that after 12 hours, xanthochromia was reliable using their method of detection, but didn't say anything about patients under 12. What is useful, I think, is that serial sampling provides us with a good endpoint as to when xanthochromia should still be reliably detected. As you can see from the table, absorbance peaked at around the 1 week mark and remained more elevated than 12 to 24-hour absorbance until well after 2 weeks post-headache onset. So although we don't know the specific absorbance level that translates to visual detection should be easiest when light absorbance is highest. So what this means for us is that we should have a good chance of detecting xanthochromia up to 2 weeks post-event. Now, for us in the emergency room, this delayed time to appearance of xanthochromia, however long that may be, poses a challenge because we are often seeing these patients right after the start of their headache. And as it turns out, despite lumbar puncture being a mainstay in the workup of subarachnoid hemorrhage for decades, there's no widely accepted definition for what makes an elevated RBC count. And the reason for this is the traumatic tap, which occurs in anywhere from 10 to 30% of LP attempts. A commonly held misconception is that you can safely call something a traumatic tap if the RBC count declines by 25% from tube 1 to tube 4. But the main flaw in this logic is that you can have a traumatic tap and a subarachnoid hemorrhage. So this decline alone is not sufficient. So again, Dr. Perry and colleagues set out to find an answer to this question with their study of differentiation between traumatic tap and aneurysmal subarachnoid hemorrhage. This was a prospective, multi-center cohort study at 6 Canadian EDs and was actually a pre-planned sub-study of the work that was already being done on the Ottawa subarachnoid hemorrhage rule. They included patients with non-traumatic headache peaking within 1 hour, no focal deficits, and they had to have undergone both a CT and a lumbar puncture. 5 of the 6 sites used visual inspection to detect xanthochromia. The primary outcome was aneurysmal subarachnoid hemorrhage. And their goal was to try to figure out what RBC threshold reflected a traumatic tap. So looking at the flow diagram for this study, we see a total of 1,739 patients were enrolled and had both a CT and an LP. 36% of these had an abnormal lumbar puncture, and 98% of those were actually false positives. Only 15 patients had aneurysmal subarachnoid hemorrhage in this cohort, and interestingly, 10 of them were actually picked up on CT on the final radiology read. This gives LP a number needed to treat of 337 in this study to pick up 1 aneurysmal subarachnoid hemorrhage. Of those 15 patients, 7 were positive for xanthochromia. If we look at only the LPs done beyond 12 hours, it doesn't get much better, with only 54% sensitivity for xanthochromia. I think this makes it abundantly clear that the xanthochromia cannot be relied upon in isolation. Using receiver operating curve to assess the optimal RBC cut point, they landed on a number of 2,000 times 10 to the 6, which captured 14 out of 15 patients, or 93%. Combining the two, which means that a tap is positive if either xanthochromia or RBC is greater than 2,000 are present, and we get a sensitivity of 100%. But I will draw your attention to the wide confidence intervals, which go as low as 75% for sensitivity. And this, of course, is because these results come from a total of 15 patients. So in an absolute worst case scenario, if we were to use sensitivity value of 75%, we get a likelihood ratio of 0.27, which isn't overly strong. But again, this is the absolute worst case. And if we take a Bayesian approach and use our post-CT pre-LP probability of 0.6% that we found in our group of patients that present after 6 hours, we get a post-test probability of subarachnoid hemorrhage of 0.2%, or 1 in 500. Being more realistic, this number is probably well over 1 in 1,000. What about the drawbacks to LP? Well, the most common complication is the dural puncture headache that occurs in up to 40% of patients. Although these are often self-limited, headaches can be quite severe, sometimes even worse than the initial headache. They can take a week or more to recover from, and they often lead to repeat ED visits, and in some cases even require a blood patch. Techniques to reduce this include using non-cutting needles of a smaller gauge. The other complications listed, I think we all know, but another significant drawback to the lumbar puncture is increased ED length of stay that ranges anywhere from 2 to 4 hours, depending on the study. In our ever more crowded emergency rooms, this may be a consideration. As we saw, there is a relatively high rate of false positives depending on the RBC cutoff used. In a worst case scenario, this will lead to 30% of patients getting a CTA anyways, even though the LP path was chosen. And finally, patients don't like this procedure, with some studies quoting refusal rates of over 20% despite strong recommendations. So to summarize this section, here are a few takeaways. There's no good evidence to support waiting 12 hours before performing a lumbar puncture. The threshold of positive xanthochromia or RBCs greater than 2,000 times 10 to the 6th was established in only 15 patients and should be prospectively validated. A negative lumbar puncture likely decreases the post-test probability of subarachnoid hemorrhage to less than 1 in 1,000 following a negative CT scan using a Bayesian approach. But for higher risk patients, you should probably use a lower RBC cutoff at this point. So this brings us to the final topic I want to talk about, and that's the CT angiogram. With improved multi-row CT scanners and superior software for imagery formatting, the less invasive CT angiogram has largely supplanted invasive vascular studies as the modality of choice for investigating cerebral aneurysm, as well as making treatment decisions. All patients who have a positive CT scan or a positive LP will now go on to getting the CTA to look for aneurysms, and less commonly other vascular malformations. More recently, some practitioners have moved to using CTA instead of the LP for the initial workup of subarachnoid hemorrhage, with the rationale being if there is no blood and no aneurysm, there can be no aneurysmal subarachnoid hemorrhage. This statement is based on the assumption that only aneurysmal subarachnoid hemorrhages matter. If we look at the etiology of subarachnoid, we see that the majority of patients are aneurysmal at 85%. 5% are a catch-all group of other, which include AV malformations, dissections, and bleeding from tumors. Then the final 10% have no bleeding source identified despite extensive workup. Regarding the other group, CTA is the initial test of choice to detect cerebral AV malformations and cervical and vertebral artery dissections. Tumors are likely to be picked up on the plain CT. So what we're left with then is a subgroup of subarachnoids where no bleeding source is identified. And within this group, all we really care about is radiology negative hemorrhages. Because by definition, the first two on this list are plain CT diagnoses. You can't diagnose them if you cannot see them on CT. So what I mean by radiology negative hemorrhages are those that are picked up on lumbar puncture where both CT and CTA are negative. These make up only about 0.5% of all subarachnoids. And the question is, should we care about them? Most of these never end up having a clear bleeding source identified and are believed to be caused by venous bleeds. These patients typically do not experience vasospasm or hydrocephalus and typically have good functional outcomes. Talking with our local experts, Dr. Sinclair and Dr. Mohammed, if these patients are identified, they are being admitted to the hospital. But the reason for this admission is purely to identify vascular causes that may have been missed. These patients get formal invasive angiogram, potentially an MRI of the spine to look for cervical AV malformations, but the yield on these tests is low. So if CTA is effective at identifying aneurysms, then the CT-CTA rule-out test is probably an effective approach. So let's see if CTA is any good. This paper, published in Radiology in 2011, is a systematic review and meta-analysis that included a total of 50 studies, both prospective and retrospective from 1997 to 2008. This analysis only looked at patients with proven subarachnoid hemorrhage. The primary outcome was sensitivity and specificity of CTA at identifying cerebral aneurysms. In greater than 70% of studies, the reference standard for aneurysm was surgery, coil placement, or autopsy, so aneurysms we actually care about. In the remainder, formal angiogram was the reference standard. And the results show a sensitivity of 98% at identifying cerebral aneurysms with tight confidence intervals between 97 and 99%. The strengths are that this was a large systematic review, again, included 50 studies. They included mostly prospective studies, and the study quality was strong and assessed using the QuadS tool. The limitations was that there was moderate heterogeneity in the data. There was likely some publication bias, as smaller studies and those with negative results are less likely to be published, leading to potential overestimation of diagnostic accuracy. And finally, this wasn't an ED population. But because CT followed by CTA is not standard practice, there's no study that directly looks at this. Nonetheless, in an ED population with lower pretest probability of disease than we saw in this study, all that's really changed is that CTA may detect more asymptomatic aneurysms, but the sensitivity of detecting aneurysms should be no different. So back to our nomogram, and I think at this point you get the idea. Using our numbers of 98% sensitivity and 100% specificity, we get a very strong negative likelihood ratio of 0.02 for the presence of an aneurysm. Using our number of 0.6 for patients having a subarachnoid hemorrhage post-plain CT in the after 6-hour group, the post-CTA probability of a missed aneurysmal subarachnoid hemorrhage approaches 0. Now, I will tell you that this is not the case. The miss rate for this approach is not 0. And that is because we have had to make one big assumption, and that is that CT and CTA are completely independent tests with no degree of overlap. The factors in favor of this assumption are that they look at two different disease entities, blood for CT and aneurysms for CTA. The factors that would decrease the sensitivity of CT would include time from headache onset, volume of blood, and hemoglobin concentration. Factors that would decrease the sensitivity of CTA would be the size of the aneurysm, location near the skull base, motion artifact, and injection timing and technique. So far, so good. The factors against this assumption would be that both tests use the same technology and are interpreted by the same radiologist. The second is probably more important. If, for instance, you have a more junior radiology resident reading scans overnight, there may be a higher likelihood of misses on both CT and CTA. With this said, this could also have the positive effect of a subtle finding on one test, leading to more scrutiny of the other. So weighing all of these factors, I think it's safe to say that these tests are mostly independent, but with a small degree of overlap. In a study by McCormick et al. In Academic Emergency Medicine, they performed a sensitivity analysis using a high degree of overlap of 50% to look at what is likely a worst case scenario. And despite this, they found a post-test probability of aneurysmal subarachnoid hemorrhage of 0.5% in an ED population when both CT and CTA were negative. And again, this is with the overly conservative assumption of a 50% overlap. In reality, similar to LP, our miss rate will probably be less than 1 in 1,000. There's one other major benefit to CTA, and that is additional diagnostic yield. As emergency docs, I think we need to be considering alternative diagnoses to subarachnoid hemorrhage when we're assessing patients with primary presentation of a thunderclap headache. So cerebral venous sinus thrombosis. By no means am I advising to pursue this diagnosis on everyone, as it's rare. but it is more common in the peripartum period, affecting about 1 in 10,000 pregnancies. Other risk factors include OCP use, sickle cell disease, and other prothrombotic states. Headache is the most common presentation. It can present without neurological deficits, and although the headache is typically gradual, 10% do present with a thunderclap. Perhaps most surprisingly is the exceptionally high sensitivity of multi-detector CTA at making this diagnosis. In a 2000 paper by Lin et al., sensitivity was found to be equal to that at MR venogram. Cervical artery dissection. So headache is the most common presenting symptom, and 13 to 22% present with thunderclap. Over half have neck pain, and although it's often associated with neurological symptoms, headache may precede these symptoms by the order of several hours. And of course, CTA is our test of choice. Finally, this brings us to RCVS. If you haven't heard of this diagnosis, it's because the term reversible cerebral vasoconstriction syndrome was first coined in 2007 and is a unifying diagnosis for multiple vasoconstriction syndromes. It is caused by reversible segmental vasospasm in the circle of Willis. Thunderclap headache is reported in 94 to 100% of patients and can be the only presenting symptom. Although there are many diagnoses that can present with thunderclap headache, RCVS, along with subarachnoid hemorrhage, are among the few that present primarily with thunderclap headache. As literature continues to emerge, it may actually be the most common cause of thunderclap headache for all comers. Patients have a mean of 4 thunderclap attacks over the course of a 1-month period, at which time symptoms typically subside. After 3 months, by definition, vasospasm is no longer detected on CTA. Over 50% of cases are precipitated by either the immediate postpartum period or vasoactive substance use, including serotonergic and sympathomimetic agents, as well as marijuana. Over-the-counter cold medicine like Sudafed is a common example. Common triggers include exercise, sneezing, coughing, and sex. I'm going to try and keep this PG. So who cares? Why does RCVS matter, particularly in the emergency room? And while it is true that most patients with RCVS have good prognosis and good functional outcomes, there's an approximate 1% mortality. Additionally, there is a relatively high incidence of negative sequelae, which include intracerebral hemorrhage, cerebral infarction, PRES, and persistent neurological deficits. These risks appear to be higher in the postpartum subgroup. Importantly, these sequelae are potentially avoidable. The neurology group is currently admitting all of these patients because at present, there's no good way to identify who is at risk of a bad outcome. They are all treated with calcium channel blockers. So I would argue that this needs to be on our differential, particularly for patients with recurrent thunderclap headaches or risk factors such as vasoactive drug use or in the immediate postpartum period. CTA is going to be our test of choice. So the main drawbacks to CTA include increased radiation exposure, contrast allergy, and the identification of incidental aneurysms. Applied to our typical 50-year-old patient that we're worried about subarachnoid hemorrhage in, the increased radiation would result in about 1 additional malignancy for every 1,000 CTAs. Contrast allergy, which is reported about 1%, is much less common when we're talking about serious reactions. But then perhaps most importantly is the propensity to identify incidental aneurysms, which occur in about 2% of the population. Depending on the patient, this could have very real psychological effects. Intervention is not benign, with morbidity associated with coiling being quoted at about 2%, including periprocedural stroke and aneurysm rupture. So to summarize the CTA section, CTA rules out aneurysmal subarachnoid hemorrhage with similar efficacy to the lumbar puncture. CTA has the added benefit of investigating for alternative diagnoses that should be on our radar. Drawbacks include radiation, allergic reaction, and the psychological burden of identifying asymptomatic aneurysms that can lead to very real harms. So based on my review of all the literature, this is where I've landed. If I think a patient still needs further testing beyond just a plain CT, my next test will be a lumbar puncture when subarachnoid hemorrhage is my only concern. And this is just because I think the harm of identifying asymptomatic aneurysms is potentially quite significant. With this said, I will be going with CTA when I'm entertaining the possibility of an alternative diagnosis. There are clear contraindications to an LP, or I think the LP is going to be anatomically challenging. Beyond the obvious clinical findings, I'm considering an alternative diagnosis in patients with significant neck discomfort, recurrent thunderclap headache, or in patients in the peripartum period or using vasoactive drugs. Obviously, shared decision-making with the patient is always indicated and may alter this approach. But let's just make sure we're using the right numbers when we're having this discussion. So to conclude, I just want to touch on the two cases that I sent out. The first case was a 45-year-old guy, headache peaking over 30 minutes, no high-risk features, normal exam, 8 hours from headache onset. This is how the group responded, with most people following a CT LP approach. Interestingly, about 20% chose CT only, and another 20 chose straight discharge if their headache improved. Personally, I think CT alone is reasonable in this patient. Sensitivity is probably somewhere in the mid to even high 90s at 8 hours. Pretest probability is lower in this above 6 hour group in the absence of high-risk features. He has a post-test CT likelihood of subarachnoid hemorrhage of about 1 in 333. Case 2 was a 54-year-old lady with that classic story. She has neck pain, and this is her second thunderclap in a week. She's on serotonergic agent and also an ergot. She was transferred from peripheral hospital and is 8 hours from headache onset. This is how the group responded, with most people going with the CT LP approach. This patient is clearly high risk and needs more than just a plain CT. The headache a week ago makes you think of either a sentinel bleed or potentially RCVS. Her medications are known triggers for RCVS. Her neck stiffness makes you think about the possibility of dissection. Taking all this into account, I would go with the CT-CTA approach here. If your acceptable miss rate is 0, as a few people listed, then you would need to triple up. If these scans are normal, an outpatient neurology referral would likely be reasonable. So I'd just like to thank everyone for their attention, and I'm happy to take some questions.